questions, so I'll go ahead and share my screen. Dr. Morrison, I have your case. You know what to do, so just tell me when you'd like me to scroll up or down. Thank you.
Thank you, Mitra. So I've got just kind of a quick presentation for today. So someone I just met Friday is a 38-year-old male that was brand new out, that I forgot to change his gender on the case presentation form. It's a male, and a Caucasian on Medicaid. So the questions for the case are what the guy come in, he was co-prescribed benzo and Suboxone. So is there a Coates model for that situation where someone is coming to you from another program? Do you guys have a special scenario there now to accommodate that? If not, how do you handle that? Do you go elsewhere? You tell them just, do you continue the Suboxone and tell them they have a certain amount of time to come off the benzo? What would happen there? How would you manage it? And then if it was decided that he was not, if you were going to require him to come off the benzodiazepine, would you have like a set point, like a parameter that like, if you didn't do this, you're not going to prescribe Suboxone anymore? Like how much time would you give for that to happen, or what would your expectations be? Or would it just be, well, another doctor said could have benzos with Suboxone, so we're going to do benzos with Suboxone? Now, this particular patient did not require me to write the Klonopin. He could get the Klonopin elsewhere. He just wanted me to continue writing Suboxone. And I don't know the exact details on how this came to be, but so I've got 33-year-old male. I don't know, I said 38 because that's what is at the top. I didn't update the top of the form. So my last presentation was a 38-year-old female. So 33-year-old male. He was transferring care. He's been going to a program about 30 minutes away for years. Mostly he had been on Suboxone mostly 16 milligrams, but occasionally he had been cut to 12. A lot of the prescriptions on the Board of Pharmacy were 1 in 3 and 5 days, but a lot were like 15 and 30 days. It fluctuated over the 5-year duration that the Board of Pharmacy will show. The patient told me he'd been in treatment for 7 years at various clinics consistently, and he said he had never failed a drug screen in all of that time. And he had been co-prescribed buprenorphine with clonazepam. It was Suboxone with clonazepam, about 35 1 milligram tablets of clonazepam a month for 2 or 3 years straight, from 2017 to 2019. It looked like he got kind of weaned off February, March 2019, and then stayed on Suboxone for the Board of Pharmacy for about 2 years after that. Of course, he says he's never taken it except as prescribed, and that he needs the clonazepam. It helps him to be functional. Without it, he has too much anxiety. He's very anxious just talking to me. And I did already mention there was Board of Pharmacy fluctuations in the supply, so I wasn't so sure if I believed that he had stayed sober for all these years as he reported the fluctuating supply amounts, and some of them were just like one-day prescriptions, so were suspicious for me. So for the Board of Pharmacy, his most recent prescription for the Suboxone had been exactly 30 days prior. He had received 45 films for 15 days, suggesting a 24 milligram dose, but it was really a 30-day script per patient, and he had wrapper left over. So he's saying that he was just getting 12 milligrams for 30 days. So he was at the end of his supply. It was a Friday, so it wasn't going to get through the weekend at 12 milligrams. And he also had received 30 Klonopin and had 21 left just 11 days prior. So as scheduled for 1 a day, he was on track, even had not used the 11 days worth that he could have. So I explained to him, we don't allow patients to continue on Klonopin in our program. But it was a new prescription. He had not been on Klonopin for a couple of years, and saying he wasn't using it when he wasn't prescribed it. I thought he could just turn it in, start on Suboxone, drop the Klonopin. I would treat his anxiety, but he would not agree to that. He insisted on keeping the Klonopin that he brought with him, and he felt he needed it. And a very long and supportive discussion of me trying to get him to consider other options, but he really wasn't willing to stop the Klonopin. He felt he needed it for anxiety and PTSD, which he did not go into the specifics of. He requested 16 milligrams, even though this was more than the 12 milligrams that he had just been prescribed the month prior. All of the months prior to that were 16 milligrams, and that 12 milligram prescribing is really unclear where they sent it to 15 days, if that's what they meant to do. But I agreed to the 16 milligrams. I wasn't going to split hairs on that, and it was an attempt to try to get him to come back and consider just continuing the clonazepam and continuing with our program. If he had been on 16 long term, I didn't see the issue about fighting over 4 milligrams. I was able to accommodate daily, weekday pill checks on the Klonopin. And so what I said was, if you'll just come back, I'll continue writing you Suboxone just one day at a time, as long as you bring your bottle of Klonopin, and you're not taking a whole bunch at once, and you're just taking it as prescribed. And we'll talk about this more, and hopefully you can, wean yourself off of it and just continue with our program with Suboxone and not Klonopin, or find another program that does not require Klonopin to be discontinued, and I'll just be the bridge for you until you find that. So that was just this Friday. He did not come back this Monday, but he seemed happy with the agreement that I was willing to make with him. I had some uncertainty about even offering the agreement of him coming in daily, because while being on Klonopin, his prelim drug screen would always be positive for benzos, and I have a very slow return on my benzodiazepine lab test, and it's very expensive for me to get, a roughly 10 to 14 day wait, and I wouldn't be able to just check it every day because of the price. So it would be so I would have no way of knowing if he were taking large amounts of another benzodiazepine besides the Klonopin. As long as he was taking the Klonopin, it would be almost impossible to detect abuse, as long as he were making sure that the pill counts in the bottle didn't go crazy. He could just abuse all he wanted elsewhere. So I really felt like what I'd offered him was already kind of on the dangerous side. And so because of that, I'm not going to lie, I was a little unhappy that he did not come back, and that me being in the situation that I would have to be unable to really monitor the potential for benzodiazepine misuse as an outpatient. So, but I made every effort to make him feel welcome, and that I was going to work with him and do the best I could. So I don't really have any of the other infectious disease screening. I just had a very, very cursory substance abuse history, where he just said a long, long time ago he did do heroin and pills a lot, but hadn't done it in years. And so we didn't go through all the social support, and we push our behavioral health intakes now back a week or two, so that our day one discussions, we get them in quickly for the doctor to get treated, and we don't want to delay in care to cause someone to, and we don't want to overwhelm people when they first come in with oftentimes in withdrawal or intoxicated. That for day one, we don't want to do a 1 hour interview of all of the history of the earth, of their life. We do it within a week or two, but we usually are pushing that back now. So that is my presentation, and we might want to pop back up to the questions section and help refresh people on what my curiosities are. And of course, I'm also happy to have questions answered that I did not ask, I mostly just wanted to present my story and find out what you guys would have done differently.
Thank you so much, as always, Dr. Morrison. That was a great case presentation. I'll leave this, this form up here for everyone to see the questions again, like you mentioned, but did anyone have any clarifying questions for Dr. Morrison or any responses or recommendations to these questions? Feel free to unmute or chat in. Dr. Hughes said you're kind of cutting in and out there. It's still a little choppy. I think I heard drug screen, but I don't want to assume there. And I don't want you to chat in. I know you're driving, so no worries at all. Apologize about that, Dr. Hughes said.
I'll go ahead. I have some thoughts. So Ryan, one thing that comes to mind is this guy is reporting a psychiatric disorder, and we don't know anything about his history of treatment of the disorder. You know, benzodiazepines are not a first-line treatment of PTSD, definitely, and you know, there's so many other options that are probably better choices and would be safer for somebody who is on Suboxone. So he does need a psychiatric evaluation to figure out, you know, what the appropriate treatment would be or what other options there are, you know, to kind of educate him about, you know, what would be in his best interest. And then the other thing about somebody using benzodiazepines and Suboxone is that you never know how much of a benzo they'll be using. So you know, he reports that he takes 1 milligram a day, which is not that much, but does he save some and then take 5 milligrams on a day, or you know, and how much of a risk is that for overdose? And so we don't really know, or is he acquiring some off the street and taking it in addition to his prescription, or so we don't know what the behavior is exactly. And anybody who has a history of substance use is always at risk of being out of control with a medication like that. So you know, a lot of red flags to me. You know, I think it's appropriate to treat him initially and then think about, you know, what's a better option, you know, what would be a safer choice of treatment for him to address his concerns in a healthy way.
I'm just curious, does he do 12-step meetings?
I did not ask.
I don't know if you can hear me better now. My question was his drug screen. Did it show benzos or not? Because Klonopin often shows up negative on a drug screen.
Your guess is correct. There was no clonazepam in his drug screen. Or there's no benzo on our prelim.
Yeah. So it's only usually like 1 out of 3 or 1 out of 2 that show up. It would show for sure, but that's what makes Klonopin tricky. And Dr. Hirschler said 1 milligram is not that much. It's actually the most potent one, so it's equivalent to 2 to 4 milligrams of Ativan. So even 1 milligram of Klonopin can be kind of dangerous for people. It's a little tricky because if you look at the criteria or black box warning, it used to be no benzos at all for Suboxone, but now technically it says if you're stable, that the benefits of MAT are so high that you should probably still co-prescribe. Now that's a little different than code, but you know, by the letter of the law and what the FDA recommends, it's really not a no-go entirely just because of the benefits outweighing the potential risks. It's just a thought.
I think the other piece to that, Jeremy, is that if someone were to use heroin or fentanyl along with clonazepam, that'd be much greater risk of overdose than if they're using Suboxone and clonazepam. So I think that's why, you know, the decision was that it's better to co-prescribe than to allow them to be off to the races with opiates.
Yeah, and again, it's not like you're not doing anything wrong per se. Whether it fits in the code model, as I know we've had discussions before, you know, even should there be code groups where people can take prescribed benzos, it would be harder, but it's not like wrong necessarily. It's different than we're used to, and it's certainly harder to track with the send-offs and everything, and Klonopin not showing up positive half the time. But just interesting to think about.
Ryan, is it part of your scope of practice to treat PTSD or other anxiety disorders, or where are you with that kind of thing?
I try to draw the lines with bipolar and psychosis, but even there, if a person is acutely intoxicated, I've a few times sent in an antipsychotic to try to get it under control. So I wouldn't say that I have hard lines that I draw. Yeah, it would be my preference that these things be managed by a psychiatrist and not in a group setting.
As a very minor add-on, I threw in the chat one of many references for what I would call BMEs. We all love MMEs, right? So the benzo milligram equivalent to the comparative doses, kind of playing on words there, but feel free for everyone.
Thank you so much for that. I was about to call on you. I saw your chat and so thank you. Any other comments, questions, or thoughts from the group?
I think this case, thanks for bringing it, Ryan, really highlights the evolution of our care. And certainly you've seen it evolve here, and as we've trained people, it's evolved, certainly evolved in the last 20 years to err on the side of trying to keep people alive, and with what people are using, that's part of why it has evolved, because of danger of what people may be using on the street if they're not given buprenorphine may be greater than, you know, the original thought about mixing benzodiazepines and buprenorphine. Now, clearly, well, one might guess that maybe he was not entirely honest about, you know, the way he was using his benzodiazepines, but in a sense, you're not really going to get to that until you establish like a trusting relationship, and it may come out in time. Unfortunately, as you said, he didn't come back. But it is this, there's a lot more gray because of the lethality of what people are using on the street. So I think this in some ways highlights that. Thanks for bringing it.
I think there's a good chance he will come back still, because I don't think it'll be easy for him to go find someone who's cool with the situation. I'm sure he's looking. If he does come back, does anyone have any suggestions for what to do if he's got an ongoing Klonopin prescription at that time? We'll say maybe tomorrow.
Hey, this is Laura. We had one that was very similar to this. He came with a prescription. I forget which specific medication it was, but it was definitely a benzo. And he had his records and everything he brought with him. And this is what he was given at a treatment facility in a different state. And that had been his standard treatment for like 2 years before he moved here. So what we did was, you know, to not mess with that psych med. We let that continue only on, first it was twice a week we made him come in, and then we let him go to once a week. But with the understanding that he had to do a psych referral so that we could get that specialty's input on that medication. So where we are, psych referrals are very hard to get. So at current time, we are still doing this on a weekly basis, waiting for that appointment to happen. I don't know if what we did right. It's just, that's what we did.
One other carrot you could give him, Ryan, if he comes back, is if he has an active benzo script, usually Medicaid will not pay for Suboxone. So he's probably paying for one or both of these out of pocket entirely. So if you let him know, you know, part of the requirements through your insurance is that you can't be filling them together. The Suboxone undoubtedly is going to be more expensive than the Klonopin. So if that's, you know, if that could work to help dissuade him from continuing to take it, that might help.
I had a patient, she came from out west and she was in a Suboxone program there. And she has severe anxiety. They had started her on Neurontin, and she was taking Neurontin and Suboxone both whenever she came to me. And she had been doing that for a number of years. She had been stable on Suboxone for a long time. What I did with her, I did leave her on I decreased her dose of Neurontin, and I did decrease her dose of Suboxone, but I do have her on both of those. She came in weekly to get both of those prescriptions for several months. And I mean, she does pretty well on it. I mean, I don't know if that's ideal, but I don't guess it's ideal. But I mean, she had stopped taking it for a while, the Neurontin in the beginning. I was like, no, I can't do both. Definitely not. And she really struggled emotionally, relationally, and you know, we could see things starting to decline. We came up with that compromise of decreasing the Neurontin dose and also decreasing her Suboxone. She's only on 4 milligrams of Suboxone, and she's doing rather well. For my regular behavioral health patients, I do use Neurontin sometimes as a substitute.
Thank you so much for sharing that, Sarah and Laura. Dr. Morrison, did you have any other questions about the case? I know you had those 2 questions. I didn't know if they were fully addressed or anything, but.
Yes, I just want to appreciate everyone giving me their input and suggestions, and I really appreciate everyone here. Thank you so much. I feel like you can move on now.
Excellent. Thank you so much, as always, for the great case presentation, Dr. Morrison. Alrighty, so we'll move over to the didactic portion of the session. We have Dr. Mahoney and Jen Martin here joining us today to guest present. So I can go ahead and share my screen. If you prefer sharing it on your end and advancing your slides, you're more than welcome to do that as well. Just let me know.
Yeah, I think if I could go ahead and do it, because I've made a few changes.
Absolutely. Let me make focus. All right, and I'll turn things over to you. Thank you.
Perfect. You all see that screen okay?
Yes, sir. Thank you.
Perfect. All right, good. So yeah, so thanks so much for giving us the opportunity for Jen and I to come talk today. You know, I figured it would be a good opportunity to talk a little bit about the current neuromodulation protocols we have going on at WVU with the Rockefeller Neuroscience Institute, particularly from a eligibility standpoint, you know, with all the patients that you all see elsewhere. And, you know, all of the studies that we're going to be discussing involve patients that are currently on MAT or medication for opioid use disorder. So, you know, keep these in mind. We'll go through some of the inclusion-exclusion criteria. If you have any patients that you see that are struggling that you think may fit criteria, please feel free to reach out to Jen or myself. So I'll give just some brief overviews of the studies, and then, as I said, Jen will go through some of the criteria, the inclusion-exclusion criteria. No financial conflicts, funding support. Talk a little bit about one of the studies utilizing deep brain stimulation as part of a grant funded by the National Institute of Drug Abuse. And then some of my work's been funded by a Research Scholars Award through the CTSI as well. So these are the 3 studies we'll focus on, looking at transcranial magnetic stimulation, focused ultrasound, and deep brain stimulation. Hopefully at the end we'll get a chance to talk a little bit more about a different study we have, not using neuromodulation, but using more of in the wild assessments, looking at physiological monitoring and EMA, or ecological momentary assessment. We're trying to kind of do an AI type paradigm where we can kind of look for predictors of relapse so that we can intervene before relapse occurs. So hopefully we'll get a chance to talk about that a little bit about that at the end. So yeah, so as I mentioned, you know, we in no way think that neuromodulation, regardless of form, is just going to take the place of current behavioral interventions and treatments, nor do we want it to take the place of medication as well. We really look at it more for as an adjunctive treatment. So this could certainly be good for those who are, you know, are on medication for opioid use disorder, but are still struggling either with opioids or other substances, as well as those substances that don't have any pharmacological treatments. Obviously, meth has been on the rise again. It never really went anywhere, but it's certainly on the up again. And then, of course, co-occurring opioid and meth use remains high, you know, additively contributing to overdoses. And I know that folks are really struggling with that because there's no other, you know, approved pharmacological interventions for meth. So, you know, neuromodulation may be able to kind of bridge that gap a little bit. Here's a little background. This is a review paper we put out last year. You know, over the last 20 years at different types of neuromodulation, there's been TMS. You know, it's kind of been there for a while. There's other different forms now that are that represent the blue bars. You know, that are kind of coming up, and I think it shows that we're just going to have a lot more tools in the toolbox going forward. You know, some of them, as we'll talk about, are more invasive than others, so they may not be appropriate, but we certainly have more options in this, you know, as technological advances are being made. You know, certainly we want to kind of get them implemented in a treatment the best we can. So I'll go mechanistically, I'll go just briefly into this. So, you know, when we look at neuromodulation, or really any sort of, you know, pharmacological treatment as well, you know, the areas of the brain that we want to target. So, you know, when we look at addiction, the two main areas, of course there's several, but the two main ones we focus on are the prefrontal cortex, so the more cortical regions involved with decision-making, inhibitory control, planning, those types of functions, and then those subcortical regions. So the nucleus accumbens, considered, you know, the center of the reward circuitry, has a lot to do with craving and, you know, reward processing and emotions, behavioral regulation. You know, so those are the two primary areas that we focus on. But as I said, they're all very much interrelated. You know, this is one, Nora Volkow, the director of NIDA, her and George Koob, the director of NIAAA, put together this diagram, circuitry. So as you can see, it involves several different areas, the nucleus accumbens and the prefrontal cortex, but also other areas as well that are involved in kind of the addiction process. So when we look at neuromodulation, there's two different approaches. This top-down approach, which you can look at it just as that. So, you know, starting off at more cortical, more of the outer areas of the brain, working downward. That would be a top-down approach. Then you have a bottom-up approach, which is starting kind of in the center and the core of the brain and then working its way outward. Start off with the top-down approach, transcranial magnetic stimulation, TMS. The primary target here for substance use disorders, the dorsolateral prefrontal cortex. There's also been some work done with the medial prefrontal cortex. You may have heard of it as it's approved for depression. It's also recently approved for obsessive compulsive disorder. You know, there's been a lot of pilot studies done for substance use disorder as well, and they've shown that it's TMS, when applied to the prefrontal cortex, can reduce cravings and reduce substance use for alcohol and nicotine. There's a study that came out recently looking at meth use. So it found that it could reduce the craving and use of these substances. This is a pilot study we put out last year. One of the first cases that we did here at WVU, where it was a polysubstance user, an individual who used both heroin and cocaine. Found that 7 sessions of TMS reduced cue-induced craving. So when this individual was presented with cues, substance-related triggers. So it was pictures of people using and drug paraphernalia. After receiving TMS over the course of these 7 sessions, his craving, decreased significantly. You can see there. So it's a single case, but it kind of lets us know, that we're at least in the right area. Some of the advantages and disadvantages of TMS. So, it's non-invasive. It's got a very low side effect profile as well. Other than the cost of the machine and everything, it's pretty, the ease of administration is definitely, another positive aspect. The disadvantages, it lacks spatial resolution and specificity. You can't really, we aim for the, entire left dorsolateral prefrontal cortex. If we wanted to get into really specific, brain regions, it's difficult to do that since it lacks that resolution and specificity. And it also is more cortical, as I said, so you can't really target those deep structures like the accumbens. So we currently have a study going on here at WVU where I'm going to let Jen talk a little bit about the criteria. We're not currently enrolling yet. We have another couple of studies to get out of the way first. So I'm hopeful that we're going to start screening and enrolling in within the next couple of months. So by early fall, I hope. So yeah, Jen, if you want to take it away and just talk a little bit about the inclusion, if you wouldn't mind.
Yeah, for sure. So for TMS, we're looking for men and women ages 18 to 60. We're looking for people who primarily are seeking treatment for OUD in relation to other substance use disorders. And with that, what we kind of say is generally with, if they're in the COPE program, then they're probably primarily there for OUD, even if they're maintaining abstinence from things like opioids while they're on Suboxone, but they're still using other substances, that's all right, just because that's generally just from the Suboxone kind of doing what it's supposed to do. Otherwise, we are looking for people that have like that strong desire for treatment. They definitely want to be getting better, even if they are frequently relapsing. Generally just want to see people that are compliant with program requirements and that we can kind of rely on coming back to these repeated sessions. In terms of exclusion, anybody with a seizure disorder, withdrawal seizures are okay. They're not exclusionary under updated protocol. Anybody with moderate to severe TBIs or current active suicidal ideation. Also the TBI with loss of consciousness or any other comorbid major psychiatric illness like schizophrenia, bipolar disorder, things like that. Primarily what we've kind of been looking into is people that are really struggling and do have those repeated relapses, but maybe don't meet criteria for some of the more invasive procedures like DBS for whatever reason. A lot of those folks we think could be good fits for something like TMS.
Thanks, Jen. Yeah, so I think in terms of the studies that I'm going to talk about today, this has the most favorable side effect profile. So inclusion criteria isn't nearly as bad as or as rigid as some of the other studies. So yeah, I'll move on to the next one. So moving away from the top-down approach into the bottom-up, low intensity focused ultrasound. It's been around for a while, but it's been more, focused ultrasound's been around for a while, but used more for high intensity. So for creating lesions, it's FDA approved for tremor, and it's been used for like tumor resection. There isn't a lot of work that's been done for neuromodulation. If you take a look at this video here, here's how it works. It's MRI guided. So an individual goes in the MRI, they have this helmet on. And as you can see, there's these different ultrasound waves that come in from hundreds of different angles. So no one area of the brain, gets a lot of that intensity, gets a lot of that heat. And it's able to focus in and, precisely target whatever area you're looking to target. So in this case, the next study that I'm getting ready to talk about, deep brain stimulation, the target that we want to use for low intensity focused ultrasound is that center of the reward circuitry. So focus in on the nucleus accumbens. So, you know, in theory, all of it makes sense. You know, you basically, you stimulate that area of the brain, the nucleus accumbens, you know, and you're able to somewhat regulate the dopamine release. When we look at kind of how we look at the different theories of substance use, you know, when someone uses a substance, they get the surge of dopamine, which then reinforces further use. And then it comes back down, they go through withdrawal, and then, you know, they crave, and then they want to use again, they use again, dopamine goes back up. Over time, though, it depletes so that they're just using to get back to their baseline. So just getting enough dopamine to fire to get back to their baseline level. What we want to do with these treatments is regulate it so that we're able to get them back to their baseline level with the stimulation or the neuromodulation. That way that they're able to kind of better engage in treatment. Their mood should certainly improve as well. So it's really to help them do well and be successful with the standard level of care. So it's a way of just kind of resetting that reward circuitry. Some of the advantages of low intensity focused ultrasound, you know, it's relatively non-invasive. There's a head frame that needs to be placed. So the head frame gets fastened, you know, but there's no penetration of the skull or anything. It's just fastened to the head, because you wouldn't want it to move. Obviously, when they're in the MRI, you wouldn't want them to be moving like this, because if that happens, then you don't really know where the sound waves are going, and you lose, you know, the precise target that you had. So you want their head to be completely still. Another advantage, obviously, you can target those deeper subcortical structures like the accumbens. Disadvantages, I think, you know, it's not really a disadvantage, but, you know, more research is needed. You know, we've completed this this procedure on 2 individuals with substance use disorder so far here at WVU. As far as we know, it hasn't been done anywhere else in the country or in the world. You know, we're planning on, now that we completed 2 successfully and everything was safe, we're going to be recruiting again very soon to enroll 2 more individuals at a slightly higher dose. And at that point, you know, we're going to be, hopefully by August, we're going to be writing a grant to the National Institute of Drug Abuse for a larger clinical trial to really see, you know, if we can get some positive effects. So right now it's really just very, very preliminary. And then, yeah, Jen will talk you through a little bit of that inclusion criteria as well.
Yeah, so some of the criteria is a bit similar to TMS. Again, we're looking for men and women ages 18 to 60 and primarily seeking treatment for opioid use disorder. We also really want to see that strong desire for treatment. I think that's most relevant for this protocol, just because we're not expecting, since it is like a low dose at this point, we don't know necessarily how much of a reduction in craving we could expect to see. So, you know, we can't really sell this as something that is definitely going to reduce cravings significantly for these individuals. So we kind of need people who are going to be interested in just giving back, contributing to research, and just doing what they can to help others with substance use disorder. So essentially, we've been kind of talking to those people that, you know, are going to be doing things like being a peer recovery coach or, you know, in that kind of path, and then just show that kind of motivation to help others. So for this one, we're going to be recruiting from Center for Hope and Healing, which is our residential program over here, as well as our weekly and bi-weekly COAT groups here. We previously were looking at people with about 90 days of abstinence, and we are looking to lower that a little bit just to kind of get a stronger craving response to the drug cue images that we show. They also have to be willing for a head shave and a frame placement. And in terms of exclusion with this one, really what we've run into the most is just people who are unwilling to be in that stationary position for the amount of time that it takes for the procedure, like say people with claustrophobia and that, and just aren't able to handle that sort of a confined environment for that long. History of a suicide attempt. And then with Hep C, it's not exclusionary, but it does need to be just well controlled, and they need to have, you know, fairly normal lab work. Also, any non-substance induced major psychiatric disorder like schizophrenia, bipolar, things like that. So that's about it for focus ultrasound.
Great, thanks, Jen. And yeah, so with this, you know, the hope is that within the next year, the company that we're working with, Insight Tech, is the name of it. It's based out of Israel, and they've been working with the FDA to get both a shaveless and a frameless device approved. You know, that would definitely kind of remove the burden. You know, one thing that I'm going to be proposing to the National Institute of Drug Abuse is that we do a protocol that eventually, in about 3 years from now, after we finish the first phase, we are able to do repeated sessions of this. So if you have to put a frame placement on every time, that's too much of a burden for everybody. So the hope is that we have this frameless device, and we can have repeated sessions, you know, similar to how they do with TMS now. You know, hopefully not every day for 6 weeks, but hopefully we could see an effect a little bit sooner, since we are targeting, you know, the center of the reward circuitry. So yeah, I'd say we have 2 more subjects that we're recruiting for this right now, but then hopefully in 9 to 12 months, we'll have the larger clinical trial, and yeah, definitely opening it up. So if there's anybody elsewhere throughout the state or, you know, other locations, yeah, we'd certainly love for you to send them our way. And the last neuromodulation study I'll talk about is with deep brain stimulation. Once again, targeting the nucleus accumbens. You know, this obviously more invasive than the other studies that I discussed. This does involve a brain implant. You know, it's been used for over 30 years, you know, primarily for Parkinson's and tremor. There's also been some studies looking at psychiatric conditions that have shown positive results as well for OCD, treatment refractory epilepsy as well. So, you know, it's been used a lot, and it does have despite being involving brain surgery, it does have a relatively safe, positive safety profile. So with this current study going on right now, it's funded by the National Institute of Drug Abuse. We're in the first phase of it. It's a 2-phase study. So the UG phase, open label, have to perform the surgery on 4 participants before it moves on to a larger randomized control trial. So we're hoping that the UG3 phase, we're able to complete that in the next few months. We've completed with 2 individuals, and now we have 2 more to go. We have one that's currently being in the screening process right now, and then another one, hopefully they'll be in the screening process soon. So, you know, we're hoping to be done with this, but then once we get to the larger UH phase, that's going to be 16 patients enrolled in that. So once again, we're going to be looking out to our collaborators and to other sites to see if there's anybody that may be suitable for this study. Obviously a little bit longer and more intensive given the invasive nature. Folks for the study will come in for a baseline and screening period for 2 weeks where they're inpatient. You know, that's just really to let the individual stabilize and just to really get to know them clinically, and just, you know, make sure that they are a good candidate before the surgery takes place. We then give them a 3-week recovery period after the surgery before we actually turn the stimulator on. And at that point, once we turn the stimulator on, there's so many, you know, thousands and thousands of different combinations that you can use, from setting not only the electrode contacts, but also the frequency and the pulse width and the voltage, and, you know, so many different combinations. And it's not like it is with tremor, you know, when, you know, someone has tremor and they come in, you adjust the settings and the tremor stops. It would be nice, I think we all agree with that, it would be nice if cravings were like that, where you could just watch the craving stop, but we can't, so it takes a little bit more. So, you know, we spend about 3 weeks working with them and adjusting the settings, you know, until we feel comfortable that we have enough of an effect. They're still in an inpatient environment at that time, so, you know, we just need to make sure that it's suitable enough so that they go outpatient, because you can really, we're not getting the best sense of how well it's working until they're back in their, you know, home environment. They still come in frequently for outpatient visits. We you know, try to keep tabs on them, you know, very frequently. And then there's an extensive follow-up through 52 weeks, so through the remainder of the year. And then a long-term follow-up as well, where they come in every few months after that, just so we can look at long-term safety and efficacy. Yeah, I'll skip that. So once again, some advantages of deep brain stimulation, obviously greater precision targeting. You know exactly where you're putting the stimulator. You can target it as deep as you'd like. You know, disadvantages are pretty clear. You know, it's a surgical procedure, requires recovery. And then, you know, with any sort of implementation of hardware, you know, there's always complications that could occur, infection, those types of things. So, you know, there is obviously higher risk. And, you know, that's why a lot of our, you know, the inclusion exclusion for this study in particular is much more restricted and much more stringent. I won't go too much into the results, but, you know, as I mentioned, we've enrolled a couple of people now. First participant doing very, very well. I'll talk just a little bit about their outcomes here. Substance craving. You know, if you look at the bars here, the green is after we had the parameters optimized the best that we could. You know, you'll notice his opioid craving is low across the board, and that's, you know, to be expected actually, because he was on Suboxone the entire time, and the Suboxone's doing what he's doing. The benzos were the major problem for him. And you could see kind of during that, compared to screening, kind of downward after surgery, after we got the parameters optimized, you know, it did quite well. Craving was all the way down to 1, you know, mostly coming in, you know, saying he wasn't craving at all. And then as far as functional outcomes, you know, at this point, he's got over 600 days actively engaged with treatment, you know, works, become a peer recovery coach. So, you know, very, very, very successful. You know, we're very happy about it. You know, it's one single case, you know, and we know that this works for this individual. And, you know, we know that a big part of it has to do with his motivation. You know, we've enrolled a second participant who met all the criteria that we had, and, you know, finished surgery. Surgery was successful, safe. You know, did all the parameter optimization during inpatient. And then afterwards, after discharge, you know, patient relapsed, went off the grid, incarcerated, you know, tried to get him back engaged in treatment. Wasn't able to get him fully engaged, you know, kept having difficulties. So it really speaks that this isn't going to be the magic bullet. This isn't going to be, you know, just flipping a switch and addiction's over. You know, it takes this plus, you know, very, very, very committed kind of to their recovery. So once again, it's not going to be right for the person that thinks that it's just going to be a quick fix, and, you know, the years and years of active addiction are just going to go away with getting this device. So that's something we definitely reinforce to them. So I'll let Jen go ahead and talk a little bit about the inclusion for this.
So as Dr. Mahoney was saying, this one is definitely the most stringent in terms of the inclusion-exclusion criteria. For this one, we're looking for men and women ages 18 to 50, or actually 21 to 50. And again, primarily seeking treatment for OUD. And as we were saying, yeah, definitely the strong desire for treatment. These people, generally what we're looking for is people who have failed multiple different methods of treatment. So have tried detoxing, inpatient, outpatient basis, including medication for opioid use disorder. People that have tried and failed all of those different methods of treatment, but also keep coming back. And are still engaged and still wanting to get better and still have that motivation for treatment, even if they are consistently relapsing over the course of all of that treatment. And also we're looking for people that are at a very high risk of death. And that's just because this is such an invasive procedure, and, you know, it's something that is not going to be the first line of treatment for anybody. So this kind of has to be something that is for people that have tried everything else and it hasn't worked for them. So when we say high risk of death, like history of overdoses, IV drug use, patients who are actively seeking out fentanyl, things like that. So with this, we're looking for people with a strong support system, which can be difficult to find in this population, but we definitely recognize that going through something this invasive, you're going to need a lot of people in your corner helping you out and helping you through it. At least one lifetime history of overdose, no suicide attempts within the last 3 years, and no current active suicidal ideation. In terms of seizures, it's okay if they are withdrawal seizures, as long as they occurred greater than a year ago, but just no history of a seizure disorder. TBI with loss of consciousness or any sort of comorbid psychiatric diagnosis like schizophrenia and bipolar.
Thanks, Jim. So I know we're running a little short on time, so this is just kind of highlighting the pros and cons of each of the different 3 forms that I talked about. You know, I'm really excited right now, mainly because it's kind of consumed my life with writing this grant for NIDA that's due next month. So with focused ultrasound, just because it really seems to kind of address all the cons of the other 2. You know, you're able to target those deep subcortical areas, but it's non-invasive. You know, you're able to get there with great focality and precision. So that's something I'm excited about, but the other 2 are obviously, you know, very positive findings so far. I have this cheat sheet here, which I could make sure it gets sent out to everybody. This just kind of highlights the inclusion exclusion criteria, just the major ones. That way, you know, if you keep this nearby when you're seeing a patient, really they're struggling and you think they might benefit from something else, you know, you can kind of give us a call and refer them if you think they'd be appropriate. And once again, funding support. And that's all I got.
Well, thank you both so much. Such interesting work you both are doing, and we really appreciate your time today and presenting that. So thank you both so much. Before we end the session, I know it is 5 p.m. here, but were there any questions for Dr. Mahoney or Jen? Feel free to unmute.
James, I have a question. You know, one of the things that interests me is the placebo effect. And the thing that makes the placebo effect work, in my opinion, is the drama of healthcare. And so all these procedures have a lot of drama. Do you know anything about how potent of a placebo effect there is with these procedures?
Yeah, I mean, so I don't know, statistically, I don't know what they are, but I would say that they're definitely present, you know, to some extent. You know, when you think about it, you know, when you're doing first in the world type procedures and, you know, your treatment team turns from, you know, a few people to what seems to be hundreds of people that are kind of looking at you and, you know, checking in on you. And you know, I think that certainly plays a role. You know, that's why until we get the follow-up to the DBS study right now, it's a crossover. So it'll be a delayed start for half the group. So everybody will have the surgery at the same time, and then half the group won't have the stimulator turned on for 3 months. So we'll be able to kind of see how much of a placebo effect there is. So it's definitely there. It's just questionable how much, you know.
Thank you so much for the question, Dr. Hirschler, and the response, Dr. Mahoney. Any other thoughts or comments or questions from the group? Alrighty, well, before I get into the announcements, again, I really want to thank you both for the guests presenting today, Dr. Mahoney and Jen. We truly appreciate you guys. And of course, thank you, Dr. Morrison, for the case as well. We appreciate you. Alrighty, so our next session will be on July 12th, and we actually don't have a didactic for that day. We're trying to have a session of cases. So if anyone would like to submit a case or needs help submitting a case, I'm always here. So shoot me an email and I'll be more than happy to help as always. So we'll see you guys next time. Thank you.